Alright, welcome back you guys to the fourth lesson in our series on the endocrine system. And in this lesson, we're going to be talking about the differences between DKA and HHS. And for those of you who don't know, my name is Eddie Watson, and this is ICU Advantage. If this is your first time to our channel and watching one of our videos, and you'd be interested in more in-depth critical care educational content such as this, then we invite you to subscribe to our channel below. Make sure when you do, you hit that bell icon. That way you'll be notified as soon as our new lessons become available. As always, I truly value the subscriptions, the likes, and the comments that you guys leave, as they really go a long way to help support our channel. And for that, I do want to thank you guys. Alright, so with that said, let's go ahead and begin the lesson, and let's start to talk about DKA and HHS. And really, DKA, Diabetic Ketoacidosis, and HHS, which is hyperosmolar hyperglycemic state, they're really both hyperglycemic emergencies that are similar in some sense, but are also quite different from one another. They essentially are both states of an acute hyperglycemia in decompensated diabetic patients. And what's really important for us to know is that they require quick intervention and close monitoring, typically in the ICU. We're going to cover quite a bit of information here, but hopefully at the end of this lesson, you'll have a really good understanding of what each of these are, as well as how we're going to take care of these patients. And so with that said, let's go ahead and start right off with diabetic ketoacidosis. So our first distinction when we talk about DKA is that this is going to occur almost primarily with type 1 diabetics. Now, it can happen, but it is pretty rare for it to occur in our type 2 diabetics. And so our DKA is really defined as hyperglycemia, hypovolemia, ketonemia, anion gap metabolic acidosis. So I know that was a mouthful, and we definitely will get into explaining that more here in just a bit, but this is really our definition of what DKA is. But there really are some key characteristics that we're going to be looking for in identifying these patients with DKA. The first of these is going to be a glucose level greater than 300 milligrams per deciliter. We're also going to see a bicarb that's less than 15 milliequivalents per liter. Although in moderate DKA, we could see this less than 10, and in severe DKA, it can even be less than 5. We're also going to see our patients with a pH that's less than 7.3, although once again for moderate DKA this can be less than 7.2, and in severe DKA we're going to often see this less than 7.1. And finally our patients are going to have ketonemia and ketonuria present. And what this means is that we're going to see ketones in the blood and ketones in the urine. So now that we know what these defining characteristics are, let's talk about some of the causes for DKA. And the first and primary one that I want to talk about is really our patients who are newly diagnosed with type 1 diabetes. And oftentimes that's how these patients are first diagnosed, by having some sort of event that leads them into DKA. Other causes could also be things like insufficient administration of insulin, as well as stressful events. Also things like infection, trauma, surgery, or even pregnancy and alcohol intoxication can all lead our patients into DKA. And so what is it about these causes that leads our patient into the state of DKA? In order to really tell you about that, we're going to have to talk about the patho that goes into this. So as we talk about the patho for this, it's important to know that this can develop in less than 24 hours. So oftentimes this DKA will develop very quickly in these patients. And so it's going to be initiated by having either insufficient or absent levels of insulin. And as a result of this, glucose is not going to be able to be brought into their cells. And as a result of this, we're going to see a couple things happen. We're going to see an increase in our fatty acid metabolism. And as a result of this, this is where we're going to see our ketones. We're also going to see an increase in our liver gluconeogenesis. And this is where we're going to get glucose from our proteins and amino acids. And so we're also going to see the secretion of our counter-regulatory hormones, glucagon, and the stress hormones. And these stress hormones, like we've talked about before, are those catecholamines, the cortisol, and growth hormone. These are all released as a result of stress, and what they do is they actually will decrease the effect of insulin in being able to lower our glucose levels. But the important thing to know here is that our body is going to have more and more of this glucose in our blood, but the cells are going to be deprived of glucose at the cellular level. And so this is where we're going to see the effects of these within our pathophysiology, and we can organize this into two main components. First, we are going to see a fluid volume deficit with an electrolyte imbalance. And we're also going to see an acid-base imbalance in our patients. So first, let's talk about this fluid volume deficit and this electrolyte imbalance. So we know that due to the lack of insulin, our glucose levels are going to be high in the blood. And like we just talked about, due to the stress response hormones, we are going to further increase this glucose that is available. As well as we're also going to see the production of those ketones. In addition to that, we also have the catabolism of protein stores, which is again going to further elevate that glucose level. And so now, because we have all of this glucose in the blood, glucose actually contributes to osmotic pressure. And so as a result of this osmotic pressure and hyperosmolality, that we're going to see fluid shift from the intracellular to the extracellular space, essentially pulling fluid into our vasculature. And because of this osmotic pressure, this is going to lead to osmotic diuresis. And because we have this hypotonic loss of fluid due to this diuresis, that this is going to cause this intracellular and extracellular fluid volume deficit and the electrolyte loss that goes along with it. And so as we lose this water through the urine, we're also going to lose our sodium, our magnesium, calcium, and phosphorus. And our patient's potassium may either be low or high, depending on a few different factors, depending on if our patient is experiencing nausea or vomiting, how their fluid status is, as well as their acid-base imbalance, which we're going to talk about here in a minute. Now, for this volume deficit, if this progresses far enough, this can even lead our patients into hypovolemic shock. In addition to this, we're going to see a decrease in the GFR rate in our kidneys for glucose, which means we're going to have a difficult time clearing glucose via the kidneys, which is going to contribute to this cycle of progression that we see. And then finally, due to this volume deficit, we could see the dehydration of cells in our brain, which are going to lead us to the neurological symptoms that we see. And we will talk about those signs and symptoms that we'll see in our patients here in a minute, but next I want to move on and talk about this acid-base imbalance that we're going to see. And so we know with our cells that they're going to starve without glucose. And so the body is going to attempt to use fats and proteins to produce glucose, thinking that's what the cells need. And so specifically, as we're metabolizing these fats, we're going to see the production of ketone acids. And this is going to cause a metabolic acidosis. You're also going to see the production of acetone, which will play an important role in one of the signs and symptoms that we'll pick up on here in a minute. But if you remember, we were just talking about the fluid volume deficit and the hypovolemia that our patients are going to be experiencing, which this is going to lead to decreased tissue perfusion, causing our cells to switch into an anaerobic metabolism, to which a byproduct of that is going to be our lactic acid, which is going to further worsen our metabolic acidosis. And so because of this metabolic acidosis, that this is where we're going to see an increase in our anion gap. And normally our anion gap we're going to see is between 12 and 14. And what's happening is our body is normally maintaining a ratio of our sodium and potassium to our chloride and bicarb. And so our calculation for this, we normally add together our sodium and potassium, then we add up our chloride and bicarb, and we subtract that from the total of the sodium and the potassium. And this is what gives us our anion gap. Oftentimes, because of the low number, you'll see the potassium eliminated from this calculation, and we'll just subtract the chloride and bicarb from our sodium. And this calculation is how we determine our anion gap. But once again, because of this osmotic diuresis, we're going to see a low bicarb. And we're not going to have the bicarb available to buffer this metabolic acidosis that we have going on. And we'll see this reflected in an increase in this anion gap. And so as a result of this decreased bicarb and this metabolic acidosis, the respiratory system is going to attempt to compensate. And so what it's going to do is attempt to blow off CO2 by increasing our respiratory rate and increasing our tidal volume to try and bring that pH back up into a normal level. If you want to understand this process a little bit more, I'm going to link to a lesson that I did on our arterial blood gases, which will explain this a little bit more for you guys. This acidosis, we're also going to see spill over into an intracellular acidosis. So the insides of our cells are going to be acidotic, which is going to lead to a potassium shift. And so it's going to move potassium from inside the cell outside in an attempt to lower the pH of the cell. And then because of this level of potassium in the blood, the kidneys are going to work to excrete this, as well as we're going to lose that potassium as a result of that fluid volume loss. And so this can become a problem later because as we administer insulin in these patients, that we can induce a shift of potassium back into the cell and lead to a state of hypokalemia in these patients because we've excreted that potassium out at this point. All right, so this was a pretty complicated but interconnected pathology between this fluid volume deficit and electrolyte imbalance, as well as this acid-base imbalance that we're going to see in our patients. So next, let's talk about some of the signs and symptoms that we are going to see in these patients. The first that I'm going to mention is acetone breath. And that's a fruity smelling breath because of this acetone production, which has a fruity smell to it. We're also going to see something called Kussmaul respirations. And essentially this is rapid, deep breathing. And this is a result of that respiratory system attempting to compensate for the acidosis. These patients oftentimes are going to have abdominal pain and nausea and vomiting. You could also see an altered sensorium. These are going to be things like paresthesia, which is the tingling, prickling, chilling, burning sensation. They could experience paresis or muscle weakness, plesia or paralysis, or even aphasia, which is the loss of an ability to either understand or express speech. You're also going to see tachycardia, polyuria, which is excessive urination, polydipsia, which is going to be an excessive thirst, and depending on the extent of our dehydration, they could be lethargic, stuporous, or unconscious. And so hopefully all these signs and symptoms make sense as a result of what we just talked about within this pathophysiology. All right, so we talked about quite a bit so far here for DKA, but I actually want to move on right now and talk about our HHS. And so like we talked about with DKA, that's primarily going to be seen in our type 1 diabetics. HHS is typically going to be seen in our type 2 diabetics. But unlike type 1, which is oftentimes first diagnosed in children, it's going to be pretty rare for us to see type 2 diabetes in children. Although lately we have been seeing an increase in our childhood obesity rates, and this is actually leading to an increase in our seeing HHS in children. Now, our HHS is really defined as a hyperglycemia with a profound dehydration in the absence of ketosis. And we also have a set of defining characteristics for this as well. And for HHS, we're going to see glucose levels that are usually in the range of 600 to 2,000, although typically they're around 1,100. You're also going to see profound dehydration. and that hyperosmolality. And so the defining characteristic of this glucose level you're going to see is going to be oftentimes much higher than what we see in DKA. Now, for our causes, they're actually going to be very similar to what we see in DKA. So again, stressful events, infection, trauma, surgery, but this is where you're often going to have undiagnosed or untreated type 2 diabetes. So now let's move in and talk about some of the patho that we're going to see in HHS. And a lot of it is actually going to be very similar to what we see in DKA with a few differences. Now, the first is that the onset is often progressive and it's not quick like we see in DKA. And in fact, we can even see this happen over weeks to months. Now, in these patients, because they have some insulin that's being secreted, we're not going to see that lipolysis and thus no overproduction of ketones and ketosis. And so that means we're not going to see the acetone breath, we're not going to see Kussmaul's respirations, and we're often not going to see abdominal pain and nausea and vomiting in these patients. And because of the lack of these symptoms, this often is going to keep our patients from seeking treatment earlier. Now, because of the extremely high glucose levels that we talked about, we're going to see much higher osmotic pressure and therefore significantly higher diuresis than what we see in DKA. And this is what's going to lead to that profound dehydration. Oftentimes, our volume deficit in these patients is going to be 9 to 10 liters. We are also going to see those decreased electrolytes due to the diuresis and dehydration, but more often than not, we're going to see a normal pH in these patients. If we do see acidosis or the patients are acidic, this is going to be due to lactic acid buildup from hypoperfusion, not ketoacidosis, like we'd see in DKA. And those are essentially the differences in the patho that we're going to see with HHS here. Now, we already talked about some of the differences that we're going to see in our signs and symptoms, but it is important to know that the CNS dysfunction and our mortality rates are often going to be worse with HHS due to that severe volume loss that they're experiencing, and the fact that we're often dealing with chronically ill patients here, and so that's going to contribute to this increase in mortality. And so our concern for our patients dying is going to be a result of either CNS depression of either our cardiac or respiratory centers, cerebral edema, cardiovascular collapse due to that profound dehydration. We could see renal shutdown, or even they're at a high risk for vascular embolism. So our risk of death in these patients is definitely increased compared to that of DKA. All right, so that pretty much gives you a good overview of DKA and HHS and some of the similarities as well as some of the key differences that we see with this. And so now let's talk about our treatment for these hyperglycemic emergencies. So our treatment for DKA and HHS, it's almost identical and it revolves around 4 main areas. The first is our fluid replacement. Next is treating the hyperglycemia. The third is our electrolyte replacement. And the last is treating the underlying disorder. And so we'll start with this last one because it's the simplest, is we really need to just determine whatever the precipitating event was and treat that. Oftentimes for both DKA and HHS, this event is going to be some sort of infection. So now let's talk about our fluid volume replacement. And both in DKA and HHS, that this is going to be our priority because we want to prevent that cardiovascular collapse. And so initially we're going to treat this with our 0.9% normal saline. And often we're going to start this with a rapid bolus of 1 to 3 liters within the first hour, depending on the patient's blood pressure and their serum sodium level. And then from there, we're going to continue infusing fluids until that volume is restored. And so once our patient's serum glucose begins to come back down, we'll often switch this normal saline to a D5 half NS. And we're really doing this to prevent hypoglycemia in these patients. Typically for DK, once we reach about 250 is when we're going to do this, although we may do this higher in patients with HHS in order to prevent that cerebral edema risk. Now, as we talk about our next one here, the treating of the hyperglycemia, that this is going to involve IV insulin. And this is one of the big reasons why these patients may require frequent monitoring and therefore care in the ICU. Now, with this insulin treatment, we're typically going to be requiring more for these patients that are in HHS due to the really high glucose that we see. And we are going to see different protocols that really vary from facility to facility for these insulin infusions, but ideally our goal is to decrease our glucose level by 50 to 70 per hour. Once again, like we just talked about, we're going to switch the patient to the D5-HnS, but we're also going to decrease our insulin rate at that time, again trying to prevent hypoglycemia. And it's really important that we do keep the insulin infusion going until we have a normal pH. And this is really to avoid that intracellular hypokalemia, which we'll talk about more as we talk about our electrolyte replacement. So once again, we're typically going to see these deficits present both in our patients with DK and HHS. And if you remember, this is a result of that osmotic diuresis. Like I said earlier, we might see a worsening of our patient's hypokalemia due to an acidosis that they have going on while we're treating them. And the reason for this is, like I talked about with that intracellular acidosis, the cells are going to shift that potassium outside in order to maintain a normal pH within the cell. And so typically what you'll see in your patients, for every 0.1 drop in their pH, that you're going to see their potassium level rise by 0.6 as a result of this potassium shift. And so once again, the body's going to be excreting this excess potassium, as well as we're going to be losing it due to that osmotic diuresis. And so as we administer our insulin, that actually draws potassium back into the cell, which can cause a hypokalemia for our patients. And so it's going to be really important that we're monitoring our patient's potassium level frequently, as well as administering potassium. And our goal here is to avoid those cardiac arrhythmias that are going to be associated with that hypokalemia. We're also going to be monitoring their magnesium level, calcium level, and phosphorus level, because as we rehydrate them, it could further dilute those levels. And so typically we're going to be administering and replacing our magnesium and calcium based on our patient's serum level, but typically our phos is going to correct on its own with our volume replacement. But sometimes we are going to be giving phos to them as well. Important to remember though, in our renal patients, we want to be avoiding this phosphorus replacement. Finally, based on our patient's bicarb level and the severity of their acidosis, we also need to be assessing for replacing their bicarb. This is going to be primarily for our patients with a pH less than 7. And again, as we give the bicarb and raise that pH, that's going to cause that potassium to go back into the cells. And so we're going to really need to monitor for that hypokalemia again. All right, so that pretty much sums up our treatment here. Like I said, it's pretty much the same for DKA and HHS, and it's really revolving around making sure we get the fluids back, controlling their hyperglycemia, replacing the electrolytes, and really treating whatever the underlying disorder was. If we can do all that, we can get our patients back into a much better, more hemodynamically stable picture, and ultimately get them on their way to recovery. All right, well, we covered quite a bit of information here. The pathways for DKA and HHS are pretty complex, but I hope in talking through this that some of this makes sense for you guys, and you can see how these signs and symptoms really are a result of what's happening within this pathophysiology that we see with these processes. Along with that, hopefully you're able to really distinguish between DK and HHS, because while they are similar in a lot of ways, there are some very key differences that hopefully you'll be able to pick up on and recognize. All right, and with that said, that's going to conclude this lesson, and I do want to thank you guys so much for watching. I really hope that you guys found this lesson useful, and if you did, please leave a comment for us or hit the like button, as it really does support our channel here. In the next lesson in this series, we're actually going to take a look at the differences between diabetes insipidus and the syndrome of inappropriate antidiuretic hormone, DI versus SIADH. So, if you haven't already, subscribe to our channel. That way you'll be notified when that lesson becomes available. And in the meantime, head on over and check out the last series of lessons that we did, in which we did a great review of heart failure. As always, thank you guys so much for watching, and you have a great day.